invite Dr. Sujith Nayanar for his talk on basics of refractive lasers.
A very good morning. Thank you, madam, for giving me this opportunity. My previous speakers have already spoken a lot about the various mechanism of lasers in various. It's not coming. Okay. So, as far as my talk is concerned, it's about the laser application of laser surgery in cornea and refractive surgery, and this is the landmark paper, the excimer laser surgery of the cornea, which was published in 1983, spearheaded by Dr. Trokel, who is an ophthalmologist, and Dr. Srinivasan, who is an IBM engineer, happens to be an Indian as well. They found out that the excimer laser, which was used in engineering for cutting microchips, could be used for cornea as well, in ablating the cornea, and that could be used for reshaping the cornea for the refractive surgery purpose. And this was a very landmark paper, and which led to the most popular application of laser in ophthalmology. And of all the laser applications we spoke about, I think the slides are not coming. Excuse me, slides are not coming properly. This is one of the most popular application. The laser application that gives the wow effect. The other ones are more for treatment like retinal lasers or glaucoma laser. Patient may not feel that wow effect. So this is the refractive surgery lasers actually created the wow effect for the laser and made it so popular. And as already been discussed, among the various mechanisms of action, the laser that is being used in refractive surgery uses the technique of photoablation. And the laser which we use is the excimer laser. You imagine a cavity in which the gases argon and fluoride is filled. High energy electric current passes through it, which causes them to unite to form argon fluoride, which again dissipates. And in the process, it dissipates photons of 193 nanometers, which is directed onto the cornea. It disrupts the collagen, the covalent bonds of the collagen fibers, and the collagen fibers, it's called a plume effect. It is taken away from the cornea and which is sucked out. This is the entire procedure. And this is how the cornea is carved by the cornea surgeons with high precision, speed, no collateral damage, no deeper penetration, and no scarring. And the various procedures for which we use the lasers in refractive surgeries are the LASIK, surface ablation or the PRK, LASIK, and PTK. I hope the video plays. So it's just a video of the laser procedure, the animation as well as the video playing side by side. I'll just show the key steps, marking the cornea. The movie. മൂവ് ചെയ്യണമായിരുന്നു. ഇത് സാധാരണ സ്ലൈഡാക്കി തരും. ഇത് നമ്മൾ അതിൻ്റെ മുകളിൽ മൂവ് ചെയ്യാനുള്ള ഒരു ഓപ്ഷൻ ഉണ്ടായിരുന്നു. It's a longer video, not edited. I'm unable to play it faster. The thing is, you have to keep a microkeratome, and the cornea flap of around 130 microns is cut with the help of a microkeratome blade. The flap is raised. I think it will take more time. മറ്റേ വ്യൂ ആക്കി തരും. ഇതാവുമ്പോൾ എന്താ പറയുക, നമുക്ക് മാനിപ്പുലേറ്റ് ചെയ്യാൻ. The microkeratome is kept. The flap is lifted and the laser ablation is done. The laser ablation should be well centered on the pupil. It is all done under topical anesthesia. And once the laser ablation is done, the flap is laid back. This is what you see during the laser firing. You can see those, even the video gets little distorted during laser firing. And you can see those red blinking lights. And it's washed and flap is placed back in position and dried. In PRK or epilastic, what we normally do is, in cases like where there is no enough thickness for the flap to be made, you remove just the epithelium and put the lasers directly onto the Bowman's membrane. So here what you do, you can either scrape out the epithelium, or you can use alcohol solution to loosen the epithelium. And once it is kept for around 10 to 20 seconds, it can be removed. I'm sorry, that video is not playing properly. The alcohol is removed, then the epithelium is scraped, and you have to directly apply the laser onto the cornea. In this, you can see is on the right side, the picture is, you can see that the epithelium is it's not completely removed. The epithelium can be removed as a flap and then placed back like a LASIK flap. That is when it is called a LASIK, LASIK. In PTK, it is not a refractive surgery. It is mainly used for corneal removal of corneal opacities and scars. Here, the laser that is applied is not for reshaping the cornea, it is for ablating the corneal scars. The procedure is again epithelium removed with alcohol followed by the laser ablation. There is a particular PTK mode in the laser machine. So when you talk about the laser, success of the laser or the success of the procedure, there are different aspects in it, like the slit lamp examination, a proper topographic evaluation, the machine-based the algorithms, and the surgical factors. And complications can happen at any stage, either during the surgery or flap-related or during the laser-related. Here we will concentrate about the laser-related ones. It can be an overcorrection, undercorrection, a glare or a halo, induced aberrations, the regressions, or a decentered ablations. So for understanding this, we need to know what all things are happening in the laser delivery. There are 4 key factors in it, like beam pattern, energy, fluence, and the ablation pattern. The fluence is one of the most important. Fluence is nothing but how much energy of the laser is applied to the ablated area, because it determines how much tissue is ablated with each pulse. For every procedure, we have to check the fluence of the machine, and every machine has got specific fluence patterns for checking. In this one demonstration which I am showing is checking the fluence on the fluence plate by firing the laser before putting it on the patient, and the reference mark is getting that uniform red mark. If it is not getting, then you have to adjust the energy accordingly. If the energy is less than 15 microjoules per centimeter square, the corneal covalent bonds will not break. That means the anticipated photoablation will not be happening, because we cannot see it with the naked eyes. We will realize it only when seeing the postoperative period. The beam profile, I'm absolutely sorry, the slide formatting is completely changed. Beam profile, there are 2 types of beam profile, broad beam and flying spot lasers. The broad beam was used in earlier machines. Nowadays, we have the flying spot lasers. These are small spots of laser with high repetition rate that randomly crosses across the various areas of the cornea that is to be ablated. And various machine gives they have their own different patterns and specifications and their own algorithms, and they all differ in the laser algorithm. It's basically a machine-based procedure, and though the principle is same, there are different differences with algorithm in various things. Ablation, coming to the ablation, the higher humidity, one thing which there is Mullerin formula that gives you an idea of how much ablation can happen, but you have to understand that even the temperature and humidity changes can cause changes in the ablation pattern and rate, which I told, it will not be realized during the procedure, and only there will be surprises of undercorrection or overcorrection during the procedure. Why this glare and halo is happening? It's a known side effect. Probably it should be called as an after effect, because it will happen in most of the corneas, and it's because we are altering the normally aspheric surface of the cornea in myopic ablation, and we are inducing the higher order aberrations. There may be some pre-existing higher order aberrations which we are not treating. And pupil decentration can also cause glares and halos. So based on this, there are better ablation profiles that take care of the entire optical system rather than just the cornea. That is the wavefront guided, wavefront optimized, as well as the topo guided and aspheric patterns that is available in the latest machines. Other than the laser related complications, we should also think about the flap related complications. During the microkeratome surgeries, we can have flap tears, free flaps, buttonholes. To overcome this, the laser is being used. The femtosecond laser mechanism has already been told by the previous speaker. The femtosecond laser came into the corneal refractive surgery mainly to take care of the flap related complications that can happen during the microkeratome surgeries. In this, femtosecond directly goes to the deeper layers without destroying the surface layers, and it cuts the lamellar dissection of the cornea at the desired depth. Like even in thinner corneas, you can make up to 90 micron flap, which can be lifted. And just one more slide. And apart from the femtosecond laser, the newer method is the SMILE technology, in which even the flap is not made, and just a cut, an arcuate cut is made, incision is made, and through this, the already dissected lenticule inside the depth of the cornea is being removed. I'm sorry those videos are not playing. I'm absolutely sorry for that. And in comparison, femtosecond is definitely better than the microkeratome for a smoother interface. And SMILE is showing better results in safety as well as efficacy, and in reducing the dry eye symptoms and the corneal sensitivity. And in summary, it's one of the most popular laser technology in ophthalmology, which is ever evolving with the better and newer techniques coming up every year. Thank you for this opportunity.
Thank you, Dr. Sujith, for that wonderful presentation.